nasal, and I invited myself because we are running late. Okay. So, so why do we need to prevent infections? What specific challenges are faced? How are infections evolving in cirrhosis? Are our current prophylaxis and therapeutic options enough? And what are the future directions? So in 15 minutes, it's extremely difficult to cover all of these things, but I'll try my best. So what are the evolving challenges? We are an older patient population with several more comorbid conditions that we had ever planned for. There's a larger footprint of infections as a cause of morbidity, higher readmission rate and due to recurrence of infections, changes in bacteriology and mycology as causative organisms. The role of prophylaxis for infections might be evolving very rapidly to the point where prophylaxis may actually not be useful but actually harmful. And of course, as COVID-19 taught us, there are waves, pandemics, and emphasis on prevention, including vaccinations, are critical. So prevention of infections could be looked at in multiple different directions. Is it the first infection, or is it a nosocomial infection when someone is in the hospital? It could be bacterial, fungal, or other. And last but not the least is prevention of recurrence. So this is the cleared consortium. Many of you have been kind enough to put your patients in there. This is more than 4,000 patients across the world, across all 6 continents. We found that the global prevalence of infection was 32%. The most common site was SBP. The commonest organisms were gram-positives, and the global DRR rate was 22%. This is the clinical impact. More than 2.3 times in hospital death compared to people who were not infected, 2.1% times 30-day hospitalization, more organ dysfunction, and everything else that you can think of. And here are the differences. In low and low middle income countries versus the high income countries, there are more gram-negative bacteria and fungi, more DRO rates, and a lot of these DRO rates are actually there's less culture positivity because the patients, there's a lot of antibiotic use without cultures because there's less access to culture equipment. There's higher gram positives in the high income countries because there's more SBP prophylaxis. And there is higher culture positive rates because they use all of this, and there's higher survival. This has been accepted in the Lancet Gastro and Hepatology. I'm still awaiting for the proof. But what it tells you that whatever I tell you is nonsense until and unless you know what your antibiograms are in your hospital, not even in your country, in your hospital. This is hyper local, but this just tells you not to ape whatever the Western countries are telling you, but actually do whatever you're doing, and don't anticipate everyone else from the Western countries to do what you're doing, because we are faced with very different populations, very different organisms, and very different ability to diagnose and treat those infections compared to other places. More importantly, antibiotic resistance is a pandemic with no end in sight. There's a global failure to do this will cause 10 million deaths by 2015. So less might be more when we treat our patients with cirrhosis. So what are the levels at which infections and cirrhosis can be prevented or prognosis improved? These are the 5 levels that I can think of conceptually. The first is to prevent decompensation or advancement of liver disease. Why? Because as the liver disease progresses, there is immune dysfunction that permeates every part of the body, including the gut barrier. This results in translocation, bacteremia, as well as activation of PAMPs and DAMPs. So the multiple studies have suggested that the worse your liver disease, the worse off you are as far as the immune function is concerned and your ability to fight this infection. Worse, that there's your pro-inflammatory cytokines are upregulated, and these are ineffective. So they cause all the bad effects of high inflammation without the good impact on actually fixing the infection. So the more we can treat the disease, prevent decompensation, etiology control, the better it's going to be. In addition, the gut microbiome in patients with cirrhosis, especially alcohol-related hepatitis in inpatients, is completely whacked out, for want of a better word. There are more pathobionts, and not only pathobionts, that are pathobionts that make virulence factors, that stick onto the epithelium, that cause more adhesions, that produce lysins, that in fact make these things worse. And I'm going to talk about this a little bit more. Antibiotic resistance genes in the gut microbes of patients with cirrhosis are much worse off compared to those who are diabetes or dialysis patients. And this in turn independently leads to worse outcomes. So the gut microbiome is already conspiring against our patients, so we need to help them and not make it worse. So the other things we can do is reduce the use of medications. What medications? PPIs. Statins can reduce infections, but not in decompensated patients because they could cause adverse events. Beta blockers, there's evidence to continue until low MAP or AKI in SBP patients. So these are things that may or may not be helpful, but at least with PPI, you can reduce and remove if not indicated, because some studies have shown that they are associated with poor outcomes, including infections. Let's think about what to me is the most challenging, rethinking of antibiotic and prophylactic strategies. As I told you in the cleared consortium, there are places in the world that do not have access to culture. So if you do not have access to culture and a patient is sick, you will actually treat them with the broadest antibiotic that you have. And only then, if the patient does not react or does not get better, you will actually have a reactive rather than a proactive way of doing this. So what the aim usually is, if a patient is very sick, send cultures, broad antibiotic, follow the cultures, smaller, as narrow as an antibiotic as possible. But if you have never sent cultures because you don't have the ability to do culture, you're already hamstrung and the battle is already lost. So this is a beautiful study that was done, including places where India was here. 34% of MDR reduction in patients with cirrhosis. And remember, these were only infected people. In the cleared study, it was all comers who were admitted. 32% still there, but here 34%. Again, I told you the antibiotic resistance genes in the microbes increase as the disease progresses. More importantly, the only risk factor in the NACSELT consortium, which is a consortium across the US and Canada, was antibiotic use. All fungal infections became nosocomial. None of them came within fungal infections. And 12.7% of infections were fungal. Didn't matter what kind of bacterial infection the person has. They had to have one which presumably meant that the patient got antibiotic. This nice French study with norfloxacin did not show any mortality benefit in child's B and C cirrhosis. And in this study, again with NACSELT, we matched primary and secondary prophylaxis. And what we found is people with primary prophylaxis died more. Why is that? And we are going to come to the subsequent VA study afterwards. Most likely because patients with secondary prophylaxis are survivors. They've already survived one episode of SBP. So most likely they had something in them, in the immune system, that allowed them to survive a second system as well. Whereas primary prophylaxis, this was after they have not had any SBP at all. So the next infection that they had was probably a resistant infection that keyed them over. And this is where the problem is. Primary prophylaxis is used very patchily across the United States. There is a large group of large cohort called the Veterans Hospital, which takes care of people who are retired from the military across the US, and this is as close of a national system as you can get. So what we found, we took people who had their first SPP episode despite being on primary prophylaxis and matched them against people who had their first SPP episode who were not on primary prophylaxis. So people having their first SBPP episode despite being on primary prophylaxis indicates a failure of that medication. 2.43 times more likely to have a fluoroquinolone resistant organisms, 2.4 times more likely to have a trimethoprim bacterium resistant organism, and 3.3 times most likely to have any resistance. This led to higher length of stay and more second SBP. It told us in the VA system primary SBP prophylaxis was not effective. And this one paper that led to an antibiogram of 50% resistance against E. coli across all isolates in the VA led to the effective banning of primary prophylaxis across the entire VA system because it is useless and it's a waste of resources and it may actually harm the patients. All the things that you're not supposed to do when you first take up something for the patients. Now, primary prophylaxis is okay, things were very muddy. But what about secondary prophylaxis after the patient has had one SBP episode? It is actually even horrendous. Now in the VA and Trinetics, veterans database, they are older, more white, less diverse, more complicated. Trinetics is a national database for privately insured patients who reflect the United States population. And you can see 50% of the people were put on SBP prophylaxis and 50% of people, for whatever reasons, were not put on SBP prophylaxis. What we found that the worsening of the gap, the people on secondary prophylaxis, remember everyone has had SBP here. These were people who were appropriately started on SBP prophylaxis, and these are the people who were not started because of whatever reason. Not only was SBP prophylaxis not effective in mortality, it actually worsened the second episode of SBP afterwards. And this gap, if you can see, I don't have time to go over it, worsened over time. Between 2009 and 2010, they were overlapping. And when it came to 2015 to 2017, they were wide apart, which means the permeation of antibiotic resistance made things worse across the US. So this is actually something we may actually be harming the patient, not helping the patient. And even if you look at the Cochrane thing, it's a very wishy-washy thing for them. If you want to use it, you can, but no real benefit for antibiotic prophylaxis. So again, this means less is more. The other things, prevent hospital-acquired infections and second infections. This is very much under our control. You want to prevent unnecessary antibiotic use, early intubation to prevent aspiration, minimize urinary catheter placement, central line, etc., etc. These are pretty much obvious, but the fact is, when we are talking about a very sick patient, multiple people need to communicate with each other, and if we don't, hours are equivalent to days in this situation. You really have to do things very quickly. And to see if you could predict something, the answer is really no. Metabolites, microbiome, the AUC was 0.75. Yes, it was statistically better than the MELD score, but practically it did not give us anything. So it is notoriously difficult to figure out who is going to develop a nosocomial infection, which means everyone in the hospital is at risk for nosocomial infections. And you have to be vigilant for everything. And most of them are preventable. Aspiration, urinary catheterization, C. difficile because of antibiotics. You need to actually be very careful with this because this happens on our watch. You can't blame anyone else except us if someone gets a nosocomial infection. We need to carefully monitor patients after discharge from the hospital. This is the last part of this, but this is the most important part because if we don't treat patients adequately, they are going to come back. Because of the immune deficiency the patients have, one infection begets another. And it does not happen to be on the same site. For example, someone came in with UTI could get an SBP afterwards. But the people without UTI or SBP usually do not, because once that Rubicon is crossed, they keep on crossing that Rubicon because their immune system has technically failed. What you really want to do is just because someone has had recovered from one infection completely, make sure that if they come back with even a little bit of HE or something like that or AKI, those are the patients you really want to do things for first. And this is the most boring but probably the most effective part of this conference right here. You need to vaccinate your patients. When it came to COVID-19 in the United States, people fell apart when it came to, who was following which party. And that's when it was really critical. People were willing to go a liver transplant, but they would not get a COVID vaccine because of whatever belief they had. And it is our job as clinicians to tell people and talk to the primary care physicians to make sure people get all the vaccines they're eligible for. Influenza, pneumococcus, hepatitis A, hepatitis B, and other vaccines. These are the things that will prevent the infections the most in our patients, because if they get the flu, they'll get staph and a fungal infection. They're not going to recover from their flu. So you want to make sure that if there's an active COVID vaccine available, make sure you give it to them or encourage that it is being given, or make sure you communicate with people who are able to give this to them, because this is not directly liver care, but this is true preventive hepatology right here. This preventive hepatology will save you a lot of trouble and help your patients get better. So in summary, infections profoundly affect the national history of cirrhosis. The epidemiology and bacteriology are changing. What we really want is a high index of suspicion, but this is to actually figure out who's getting a nosocomial infection. Prevention of further infections remains a challenge. Strategies that reduce the burden of antibiotic resistance and fungal infections may potentially improve outcome. COVID-19 and other appropriate vaccines should be given to all patients with cirrhosis. Thank you so much.